Hello and welcome. This is our final session in our 2021 Sizzling Summer Series, exploring what it will take to become an anti-racist public health workforce and public health system. This summer series has been sponsored by the UNMC College of Public Health Office of Public Health Practice and our partners on the full series, the Midwestern Public Health Training Center, Wichita State University, and the College for Public Health and Social Justice at St. Louis University. My name is Katie Brandert. I am manager for workforce development and leadership programs in the Office of Public Health Practice at UNMC. My colleagues and I have been your hosts for this series. Over the months of June, July, and August, we have been hosting a series of sessions. We've covered identity, micro and macroaggressions, implicit bias, structural racism, privilege, empathy, and humility. And today, in this fifth and final session, we will be listening to three experts in the field talk about how to approach public health practice with an anti-racist lens. Before I turn it over to our speakers, a few logistics. Because of the number of people on the call today, we ask you keep yourself muted. If you have any questions for our speakers, I will be monitoring the chat box throughout the call, as will they. If you experience any technical difficulties throughout the call, please send me a private chat for support. We will be recording today's webinar. The slides will be posted. The recordings and the slides will be made available as soon as possible following the call on both the UNMC Office of Public Health Practice website and the Midwestern Public Health Training Center website. Sessions 1 through 4 are already available. We have a fabulous panel of women joining us for today's conversation. I could not be more thrilled. Montrese Ransom, Dawn Hunter, and Priscilla Keith. Montrese, in particular, we are very thankful for your coordination of today's panel and our partnership with the National Coordinating Center for Public Health Training in the National Network of Public Health Institutes. And I'm going to turn it over to you.
Thank you so much, Katie. We are excited to be here and offer this presentation, the fifth in your Sizzling Summer Series. I'm excited to share with you about our tips about what it takes to become anti-racist in the field of public health. I think it's important to note that we want this to be as interactive as possible. And so what we've done is we've created a slideshow, a presentation that allows us to have a conversation. And I hope that it inspires you to offer your questions and your thoughts in the chat box so that we can learn together. And so we've got 5 overarching objectives for our time together. We're going to highlight the legal underpinnings of the racial health inequities that we see today. We'll distinguish racism from bias and characterize the 3 levels of racism. We'll describe frameworks practical frameworks that you can use and apply to your work and really help you better understand how racism, bias, microaggressions, how they impact everyday public health practice. And then we're going to leave you with strategies for initiating and sustaining equity-focused change within your organizations. And so with that, I want to make sure you know who's on the line with you today. Again, I am Montrese McNeil Ransom. I serve as the director of the National Coordinating Center for Public Health Training at NNPHI. Prior to taking on this role in January of this year, I served for 20 years at the Centers for Disease Control and Prevention's Public Health Law Program. Also on the line are colleagues of mine and folks that I consider to be friends. Dawn Hunter, who serves as the director of the Southeastern region of the Network for Public Health Law, and Priscilla Keith, who is a lecturer of health administration at New York University Wagner's School of Business, as well as the director of the program management at RIP Medical Debt. And I'll give them each an opportunity to tell you a little bit more about their background as we dive in. But I want to set some context for our conversation today before I turn it over to Priscilla and Dawn. I want you to imagine a 6-foot-tall Black grandfather, a bushy gray mustache, his skin, maybe the color of your morning coffee. Imagine he lives in a small rural town, not too far from where you live or work. Let's call him Lewis for our purposes today. Lewis has been skeptical about healthcare his entire life. Growing up, he heard stories about the U.S. Public Health Service syphilis experiment. Notice he calls it the U.S. Public Health Service syphilis experiment. He knows y'all call it the Tuskegee syphilis experiment, but he knows better. He's heard stories of medical experimentation on slaves and the harvesting of Henrietta Lacks cancer cells for research without her knowledge. Some of his skepticism is grounded in the facts of our country's history of discrimination and exploitation of Black Americans by the US government and the healthcare system. To be clear, he's not ill-informed, nor is he prone to conspiracy theories. He says he just does not have the luxury of assuming that the government or the health system has his best interests at heart. He has a primary care doctor, but he avoids visits unless it's absolutely necessary. He says he feels rushed and is often interrupted, and talking with the physician feels like a one-way conversation. When COVID-19 struck, he wore his mask, and his grandchildren urged him to stop hosting his weekly bingo night. And so he did. But when the vaccine came out, he said, nope, not taking that. He pushed back on any conversation to convince him otherwise. And when he heard that leaders were suggesting that Black people get the vaccine first, Lewis said, now when in the history of these United States have Black folks gotten anything that's good for them first? But his grandchildren stayed on him. And the reality is Lewis had lost a few family members to the virus. And far too many of his childhood friends died due to COVID-19 complications. So James reaches out to his primary care doctor. The woman answering the phone says, oh no, honey, we're not doing that. You're gonna have to call the state health department. So he calls the state health department and they send him to a website. He's hesitant. He gives all the personal information that he asked for, and then he hears nothing. And then he tries to register on the county health department's website, and he has the same experience. In his words, you don't know whether you're talking to a computer or to a garbage can. When you're filling it out, where does the form go? I'm concerned that when I finally get to the vaccine site, someone's going to tell me that I'm not registered. So we've gone from this sense of hesitancy to access. And a lot of this is related to the history and the list of horrors in our country related to racism and what we see as microaggressions and bias that are operationalized racism in this country. So take a look at some of the snippets, the list of horrors that we've had in this country. In the Old South, enslaved persons were seen as suitable human specimens for medical experiment and demonstration. In 1839, abolitionist Theodore Dwight Weld said, public opinion would tolerate surgical experiments, operations, processes performed on slaves, which it would execrate if performed upon their master or on whites. The US Public Health Service syphilis experiments, and I'd encourage you to call it by that name. Tuskegee didn't do this. It was the US Public Health Service syphilis experiments that left Black American men with syphilis purposely left untreated by the US government. According to one study, that particular crime left such a deep psychic scar that distrust that it created reduced the life expectancy among Black men in this country by more than a year. So that heaviness, the heaviness of that history is the context that I want to lean into as we talk about what it means to be anti-racist in public health practice. And with that, I want to turn to Dawn and ask Dawn to offer a little bit more about her background and her expertise, and tell us, Dawn, what are your thoughts about approaching practice through an anti-racist lens? What does this mean to you?
Well, I am thankful also to be here today, and thanks, Montrese, for inviting me to join you this morning. In addition to working at the Network for Public Health Law, where I get to focus on health and racial equity, I also worked in state public health at the New Mexico Department of Health, and I worked in various leadership roles there. I also have a background in research and development as a microbiologist, one of my early career steps, and in child protective services, which I think is completely linked to what we currently call the social determinants of health. And actually on the slide that you just passed, you had a comment about belonging. And I wanted to lead with that because in my role at the network, I get to do a lot of civic engagement work. And one of the things that we know is that a strong sense of belonging and neighborhood cohesion is associated with better health outcomes, right? So I really appreciate that in this moment where, frankly, I think we're failing each other in our communities. And I think that the lack of cohesion right now is partly associated with our biases and how strongly they're being reinforced by current cultural, social, and political events. So on the next slide, two biases I like to talk about when I conduct trainings on equity and messaging are confirmation bias and in-group favoritism. So confirmation bias is we find and remember information that confirms what we already think to be true. So if you think that vaccines are have microchips in them as a way to control us by the government, then if you find an article or a research paper that says that, you're going to be more inclined to believe that to be true. And then in-group favoritism is, we favor people who are in our group, whether that's sports teams that we're fans of, church, our church community, alma mater, political groups in particular right now have a strong dominance. And so what I think using an anti-racist lens means is being aware of your bias, number one. These are just two. We have a lot. We have a lot of other types of biases. And then you consciously address it with some of these suggested questions. So what are your own preconceived notions about racial equity? What do you believe about people of different races and abilities? And have you ever explored that about yourself? And then how do these beliefs influence your actions? With in-group favoritism, what groups do you belong to? How diverse are those groups? Do the people that you interact with at work or in any setting really look like any of the groups that you belong to? One example I like to give is earlier in the pandemic, the governor here in Florida held a roundtable with owners of breweries to talk about the impact on small businesses of business closures. And every single brewery owner was a white male. And so having an anti-racist lens means looking at that and saying, hey, there are only white men on this panel. Where are the women? Where are the people of color who also own breweries? Because they exist here. Another good example is, and I'll put this link in the chat, is there's a recent article I read, just came out in the last couple of days, about a Harvard contract with a developer, where the developer was asked if he'd be willing to set aside 5% of the equity in the project for Black and Latino investors. And the developer agreed. And then he said, as he began looking for investors, he realized that his network was almost entirely white. And he said that was a mind-blowing revelation to him. Because it's not that those investors don't exist, is that he wasn't a part of that network. And so I think that's about being conscious of the fact that what your network looks like, and then actively taking steps to address, your own participation and kind of creating these differences between groups and between people. And so with that, I would say, I will put that link in the chat, and turn it over to Priscilla. So I think, it really starts with us as individuals, and then how that plays out in institutions and systems. And we'll get into that in a moment.
Excellent. Thank you for that, Dawn. Priscilla, same question. What does approaching practice through an anti-racist lens mean to you? And before you lead into answering that, tell us a little bit more about your background and expertise.
Thank you so much, Montrese. It's a pleasure to be here. And thank you, Dawn, for that excellent slide prior to that, so that I can lead into that. Just a little bit more about my background is that, as you know, I'm currently a lecturer at New York University, Wagner School, but I want to correct that in terms of business, Wagner School of Public Policy. So happy to be there, and also Director of Program Management for RIP Medical Debt. And what we really do there, it's a nonprofit 501c3 organization that works with donors to abolish medical debt. And as you can imagine, if you can think about that, of those populations that incur medical debt, more medical debt than their counterparts. So being in this role for the past 8 months has been extremely eye-opening in that regard. Like Dawn, I have a science background, and I actually started my career at Eli Lilly as a pharmacologist, studying ischemia and Alzheimer's, and currently had business background as well. And just one last fact with that, I spent most of my career as a healthcare lawyer, focusing primarily on regulatory work. In terms of what approaching the practice through an anti-racist lens, I looked at it from my own particular view and thought about it in terms of how I actually try to approach things through this lens. And the first one that I have here is, what is my self-awareness? And I just want to quote Ibram Kendi in terms of describing what a racist is. And he usually describes that as a descriptor. And what it really means is what a person is being in any given moment based on what they are actually saying, or more importantly, what they're not saying, doing, or not doing. And so I believe that before you can actually look to manage others or lead others, you have to have that sort of self-discipline in terms of managing or leading yourself. So when I think about it in that lens, I say to myself, what are my biases? What am I actually bringing to the table? What am I actually bringing to the discussions? Am I aware of what I'm actually saying to other people? Something that I think may be innocent, that I may have heard, may have been passed on, but quite don't understand the context or how that meaning came to be. I need to understand that. And when I do understand that and view it as inappropriate, then the role for me is to actually stop saying it and stop doing it. The second part is, am I actually being neutral or am I actually being proactive? And so I define neutrality as when you hear something that's inappropriate, when you see something that's inappropriate, do I actually not do anything about it? Do I actually not speak truth to that? Because number one, I may not actually want to offend the person who has actually said it, because that person may be a person of power, or is it in my self-interest not to say anything? So I have to really deal with my own personal thoughts and actions with that. And then third, am I receptive to different ideas? I think you heard Dawn talk about the plethora of diversity and the person who was given the task to provide or include persons of color or women into their fold with this particular business transaction. And as they began to deal deeper into looking for those people, they actually realized, the light bulb went off, that their circle of influence didn't include people other than who looked like them or who was in the same social economic status. So for me, I look to see whether or not I am taking in other ideas, other opinions, even though I may not agree with them. Do I actually listen to see what's behind the context of what's being said or what's being done? Have I taken the opportunity to expand my sphere of influence to people who don't look like me, who are not in my same socioeconomic status, whether that's a person from another group, say man, another woman, another race, another demographic group. So in terms of what does that mean for me, I try to encompass these three circles: self-awareness, whether I'm being neutral or proactive, and whether my sphere of influence includes other people who actually don't think like me and who actually don't look like me.
Priscilla, your points kind of raise a story in my mind. I was working with someone who actually was a leader of mine. And when the protests were happening after George Floyd's murder, they came to me and asked me, Montrese, do you think I'm racist? And my answer was, I don't think you're racist, but I don't think you're anti-racist. And I think that that's a key point in this conversation, this question around, am I being neutral or am I being proactive? You know, I think that we all have a role to play in being anti-racist and being intentionally anti-racist if we're going to really move health disparities forward, if we're going to reduce the racial health equity gap. I want to talk about how racism shows up in public health policies and practices now. You know, I think it's important for me that we really reconcile this history, that we understand how we got here, and we'll talk a little bit about that through our lens as lawyers. I also think it's worth pointing out that all of us, Priscilla, Dawn, and myself, we also earned our diversity, equity, and inclusion certificates, diversity, equity, inclusion in the workplace certificates, University of South Florida's Muma School of Business. And so our perspective really does come from that lens of diversity, equity, inclusion in the workplace. But all of this is applicable to this idea of reducing the racial health equity gap. We can't do it unless we're looking at things through an anti-racist lens. So this is one of my favorite quotes around how racism shows up in our work. And it comes from Will Durando, who's a county council member in Maryland. And he says, whether it's police-involved killings or disparate health outcomes where Black American patients can't get treatment because they aren't seen as being sick, or financial redlining in certain zip codes, food deserts, or people of color getting hit by cars more often because their communities aren't walkable, it's all ultimately due to racism. And when I found this quote, I immediately started saying to myself that the people that work in public health are the most altruistic people. They have the best hearts. They want to do so much to give back. This is not the type of environment that we purposely want to create, but we're all subject to these social constructs. And this comes by way of this history that is so heavy. It's the past is prologue. And so it's not so much a surprise to see disparate health outcomes based on or because of Black police-involved killings. It's not a surprise to see patients not getting treated. It's not a surprise for many of us to see that now we have opioid use disorder because the population is being impacted by addiction has changed. These are some of the ways that I see racism operationalized primarily through bias and microaggressions in the public health sphere. And so I want to turn to our panelists. Dawn, in your experience, how does racism show up in public health policies and practices in the work that you do?
Well, I want to start by saying I appreciate the quote that you had, and I wanted to share. I was prepping for something last summer, and one of the questions that was posed to us to think about in advance was, what are the ways in which public health has caused harm? And my first response was, public health doesn't cause harm. We are the champions of, healthy people and good lives and healthy communities, right? But we often, without maybe even realizing it, do things that have unintended consequences that do perpetuate some of the racial inequities that we see today. And so when we think about the way that that plays out in systems and between people, there are these three levels of racism. So the first is interpersonal. So that's the racism that exists between individuals and interactions between individuals. That could be a patient and provider. That could be also between employees in a work setting, right? And so two good examples, like in a healthcare setting, are maternal health, where physicians might dismiss the complaints that a Black mother has or other woman of color about blood clots or preeclampsia, which is part of the reason that we have higher maternal mortality rates, right, in this country. Another good example is opioids. Doctors think that Black patients have different pain thresholds. So you just heard Montrese mention that. But it's also about the way that the system is set up. So physicians and executives are often mostly white, and you have frontline workers, custodial services, assistants, et cetera, who are often people of color. And this is something that reinforces, racially based power differentials in work settings. So that gets us to institutional, which is the way that racism is created and perpetuated through policies and practices within an institution. So that could be your board composition. So the board of your organization is lacking diversity, women, people of color, people with disabilities, et cetera. But also your workforce diversity and whether or not your organization reflects the population that it serves. How money is invested in the community and how your resources are allocated. And also hospitals in particular, especially nonprofit hospitals that have a choice for community benefit spending and uncompensated care in particular, and they go after people who are low income, who are often people of color, garnish their wages, take them to court, and pursue them when they are supposed to be in the business of providing charity care for people, making sure that people in their communities are healthy. So that's an institutional issue. But it's also structural, which is about the way that institutions interact. It's about the system of laws, policies, and practices that create and reinforce inequities. And it's really going upstream. So this is about medical education that creates the physicians who believe that people of color have different pain thresholds, right? It's about access to higher education, which creates disparities in the types of jobs that people have access to. Minimum wage laws and worker protections like paid sick leave. Surprise billing. That is a result of the system of health insurance that we have in this country, and it affects all of us. So this is just where people, get billed for getting a service from an out-of-network provider without even being able to consent to treatment from that provider, if you're not familiar with surprise billing, which is why we have federal, action on that right now, and states have taken action to address that. And then opioids, right, is another kind of example of what this looks like at a structural level. So it has resulted in differences in prescribing that ultimately has impacted the white population more.
Exactly.
Right. And so when we talk about racism affecting health equity, right, and affecting health outcomes, it affects all of us. It affects everyone's health. And now, of course, prescribing practices are changing. And so we're seeing increases in substance use disorder among people of color related to opioids. But that's another good example of a structural issue. And the last thing I'll say is, when I was thinking about structural, I was also thinking about, I was talking about bias and how we have all these biases that we walk around with every day. And systems are really a bunch of collective biases, right? They're a bunch of people walking around with their bias, making decisions about other people. And so we have to be conscious of that and how that plays out in the systems where we work, where we go to school, where we live. So that's what I'll stop there. I can go on forever.
I'm gonna turn it to you, PK, but I just want to say that if you're breathing, you're biased, and bias is an operationalized racism. It's how it shows up in our everyday actions. And I'm often very careful when we talk about being anti-racist and making this connection, because bias is a protection. It's a way for our brain to say, I know that, I don't have to think about that anymore. I know this about this group of people or that type of person. And we're often wrong when it comes to our biases. And that's gotten us where we are. We're going to talk about how we got to where we are in just a few minutes. But, in my work in public health, I've been given the opportunity to hire. And I wanted to hire someone who's like me, bubbly, and wants to be on stage and wants to deliver presentations. And my bias showed up in hiring. So it's not, this is not something that we're calling out any individual. We're all subject to it. I had to have my boss, who's a white male, say to me, well, if you hire that person, we're not changing the diversity of what's happening on our team. It looks exactly the way it looks. We're all subject to these social constructs. It's important for us to take a look at what the team looks like and who's not being given opportunities. And for him coming in with that lens, that anti-racist lens, it led to us hiring for the first time on the team an African-American male who was more than qualified to do the job. It just took us looking. It took us looking and pulling through the pipeline. And it not only changed his life and career, but it changed the way we did the work that we were doing and the populations we were able to serve. And so, yes, if you're breathing, you're biased, and we've all got to do the work to overcome our biases. PK, what are your thoughts? How does racism show up in public health policies and practices from where you sit?
Oh, thank you. I wanted to take a moment to give two examples in terms of John's advocacy in terms of how the importance of having people at the table, whether it's on a board or whether it's at the executive level. The first example I can give is being general counsel of a local public health department. You have the opportunity to not only respond to regulatory issues, but also in terms of contracting. And so because you're a local governmental entity, there's a form that is filled out with the person that you're doing business with. And there's a section that stipulates that 10 to 15% of your business, as Don has said, you need to have persons of color to walk alongside you in this process. And so there was one instance where I kept looking at the contracts coming through and kept noticing that that box wasn't checked, even though it was required. And so I called in the person to ask why we weren't doing this. Why was this box consistently not being checked? And all, the business was to persons who looked like him, a white male. And so long story short, once the question was asked, it was required of that person to go out and look for people who were not like him. Women, men, people of color, who were different, who could do the job. But sometimes you have to ask that question, why isn't it being done, with the expectation that you will go forward to do that. And secondly, I had the opportunity to work on with a group of people to think about a conference. And we were dividing that conference into several different sections, one in terms of finance, the other legislative issues, and then with health equity. And when we looked at the people who were recommended, there were only white men who were recommended for finance. Why is it that only white men were recommended for finance? Secondly, for legislative issues, only women. And then there were only white women. And then for health equity, there were only people of color who were recommended. And so I asked, why are we boxing people into certain categories? Can't you find people of color who can talk about money? Why is it only white men? Secondly, with legislative agenda, why is it only white women being sectioned into legislative agenda? Can you not find a white male or persons of color to talk about what's on the legislative agenda, state, local, and federal? And then third, for health equity, why is it that we don't see a white male talking about health equity? Why is it only people of color? White males are at the top echelon of the healthcare industry. Should they not have some skin in this game? And I think when people sat back and looked at what it actually looked like, I got consensus to say, we need to change what we're doing. So I will just start with the current question because I know we need to move forward, but just wanted to put that out there. In terms of the current question, we often ask, what's wrong with Black, Indigenous people of color? Say, for instance, if the person has diabetes, why can't the diabetes be controlled when the doctor is actually given that person a way to manage their diabetes? Why do we always put the emphasis on that person's actions instead of looking at it in an alternative view? When really the lean-in question is or should be, what's wrong with the policies and institutions that really exacerbate the problem? Having said that, Montrese talked a little bit about redlining and racialized residential segregation. And we know back in the 1930s, the federal government put together the policies to increase home ownership as a result of the Great Depression. They wanted people to have more home ownership across the way. But we do know in looking at that throughout the history, that actually when they did start with this, someone actually took a red pencil and drew around those neighborhoods that mainly consisted of Black people. And it said that these people were not worthy of investment, and therefore those home ownership loans couldn't be made to them. And this did not stop until we had the Fair Housing Act, I believe in 1968. So in terms of looking at that, look how long that continued with the help and consent of your major institutions. And we can continue to see the effects of what that did to BIPOC neighborhoods where you didn't have the investment, as Dawn talked about, the economic investment to lift people out of poverty. Secondly, we have unequal access to healthcare and lack of cultural competency. Again, Dawn highlighted the high number of infant mortality that occurs among Black, Indigenous people of color. Third, we have the disparate environmental treatment and policies that continue along the way. We can see that in landfills, toxic dumps, and the rise of temperatures in those particular neighborhoods. Who are the people who most occupy the land in the neighborhoods in close proximity to that? There are Black, Indigenous people of color. And we do know the downstream effects are having to be closely associated with that, whether it's cancer, asthma, and other chronic diseases. And then lastly, with the chronic stressors and the weathering concept, I think that we've talked about that or heard about that, But when there is chronic stress that is continuous, we see that show up in high blood pressure. We see that show up in diabetes. We see that show up in heart disease. So people who are exposed to this on an ongoing basis, and that is current as well as previous generations and hopefully not generations to come, we can see that continue to show up, and people will say, oh, that's generational. But you have to ask the question, if we didn't have these policies and institutions, would that actually occur? So for me, that's really how, in some ways, it does show up in our policies and practices.
Can I jump in here really quick?
Yes,
Oh, I'm
absolutely,
sorry.
Dawn.
I'm not trying.
Yes.
So I just, on this slide in particular, so this is not a messaging training, but we do messaging training. And one of the things that I always emphasize when you're considering equity is to focus on places, systems, and conditions rather than people. Mm-hmm. And so a good example of that is when we talk about COVID, and we might say African Americans, American Indians, Hispanic and Latino people have higher, hospitalizations, deaths, cases of COVID. That's true. But what we need to be focusing on is saying COVID is higher, cases, hospitalizations, deaths are higher in communities where there are environmental hazards that predispose people to having COPD and asthma, right? They're higher in communities where there's overcrowding due to redlining. So exactly. we're not going to get rid of COVID, right? We're not going to address the problem by asking people to change their individual behavior. People can't really change and just decide to move to a different community that has fewer environmental hazards.
Especially when they have not much political power, right?
Right.
Yeah.
That's exactly it. We have instances where people have risen up to talk about those issues, and not only people who we consider the working poor, but there are instances where you have middle to upper class Blacks who have advocated for a different way, and they have not been heard. And so you can look at that from the infant mortality and what's actually happening with that in terms of African-American mothers. And the studies have shown that it transcends socioeconomic. We have story after story where you will see a well-educated African-American mother who has expressed issues with her pregnancy, who's not been listened to. And the end result is that the mother has ended up dying in childbirth or shortly thereafter. That's right,
Black
the physicians.
Women physicians, yes.
Yes. There is one, I'm in Indianapolis, and there was one who was a pediatrician. And for some reason, unfortunately, she did not survive the pregnancy, the childbirth. And so it really transcends race. You can, it's socioeconomic barriers, but I say all of that to say, Don, I appreciate you coming in and giving us the background with that. But I do want to make that example, particularly as with the example of infant mortality among African-American mothers.
Thank you for that. So we've talked a little bit about how we got here, and I want to be respectful of time. We've talked a little bit about what they call the Tuskegee experiment, which I now call the U.S. Public Health Service experiment, because again, language and reframing really does matter. It wasn't Tuskegee that did this. It was the U.S. Public Health Service. Dawn, do you want to talk to us a little bit about the Flexner report? Because I really want to get to some practice pointers.
Yeah, I will be very quick because this is perfect to what Priscilla was just talking about. And this is just, how does this happen? The Flexner report was a report that was commissioned by the Council on Medical Education for the American Medical Association that was talking about standards for accreditation that led to the closure, I think it was 5 medical schools for Black physicians, and I think 2 schools for women. Don't quote me on that, but there was a research study that came out that showed that closure of those medical schools has resulted in a deficit of 27,000 to 35,000 Black physicians today. And why that matters is because having a physician who looks like you and shares your experience affects your health outcomes. And so this study, which was on CNN, is published in CNN, it's actually in the Proceedings of the National Academy of Sciences. George Mason University researchers analyzed data on 1.8 million hospital births in Florida between 1992 and 2015, and showed that Black newborns were more likely to die when they are cared for by white doctors, and more likely to survive when they're cared for by Black doctors. I'll paste the study actually in the chat, but I think this is drawing the connection, right? A decision that was made in the early 1900s that has affected the diversity of the workforce today.
By a group of probably white men, right?
By a group of white men, right, is affecting whether or not Black infants survive today. So this is just getting you to think about the decisions that are made and the long-term effects they have on the systems that we operate in.
And to me, why it's important to have diversity at the table, because in an ideal world, a woman or a person of color would have said, hold on a minute, there's a problem with this approach. And so the idea of having folks at the table becomes even more critically important. I want to talk about racism as a public health crisis. I know that there are more than 200 jurisdictions that have declared racism as a public health crisis. And when I first started seeing these declarations, the lawyer in me was like, okay, we're making these pronouncements, but where's the money? What are we going to do with this? We've known that racism is a public health crisis for years. We've known that being vigilant around the discrimination that you're facing and the environments that you're often in as a person of color does impact your health. But it goes even further than that. And so, Dawn, I know the network in particular has been doing some work around racism as a public health crisis. Can you talk with us about that a little bit?
Yeah, I'd love to. This is actually what I spend a significant portion of my time doing, and my mind, right? That's a lot of intellectual time goes into this. But so what we have been doing is looking at declarations by each region. So these numbers on the screen are the numbers that had been of declarations that have been introduced, at least, or adopted through June 22nd. So there are slightly more than what you see here on the list, but most of these occurred last June and through last fall, although there are some that have continued into this year. And what we've been doing is looking at what these declarations say, and particularly looking at the therefore language, and what they have committed to doing. And so I will paste this in the chat as well, but we've divided that into categories that really focuses on, changing policy and practice. So looking at organizational policy and practice using racial equity tools, addressing workforce diversity issues, also putting infrastructure in place to support this work. So creating an office, a position, a task force, putting funding behind it. Probably not surprising is that most of these do not have dedicated funding, and declarations, unless they are a declared state of emergency, don't have the force of law behind them. So they're really statements of intent, but don't often have resources attached to them. But they are really an important first step for ensuring that health and racial equity are considered in both policy development and governance. And so just very quickly, some of the things that we're doing at the network is following up on implementation. So what do you do once you've issued a declaration? So we're looking at those declarations that have specifically said they're going to address adverse childhood experiences. We're looking at legislative trends for racial equity, whether that's like requiring racial equity impact statements on legislation or something like that. We're looking at where task forces have been set up. So we've read all the reports, at myself and a colleague, all of the reports that were issued and through the end of November from the COVID-19 health equity task forces, which about half the states had one, and looking at the overlap with those reports and what they recommended in those states, and the overlap with the commitments for these often very local declarations of racism as a public health crisis. We're also looking at the impact, what are the commitments to equity and aging? And then how is racism even defined in these declarations, or is it defined? And so a lot of them don't have definitions, but some of them do. And there's a lot of consistency because there are templates that have been used throughout the US. So I am working with a collaborative group of partners on implementation strategies and ways that we can guide that. And so I will share also an article that recently came out in USA Today that highlights some of the next steps that have been taken by some of these localities. One really good example that I like to share, also because I've spent a lot of time writing about this particular community and working with this partner there, is Buncombe County, North Carolina. They issued a declaration, but they had actually been doing some racial equity work starting in 2017. And so they have been intentional over the past year in engaging the community and engaging partners in developing a racial equity action plan that had clear goals, and ways to measure progress. And then that plan was actually adopted by the Board of Commissioners on June 15th. And so that's really important example of a couple of things. One is involving community, which is the most important, in communities identifying problems and solutions, but also being intentional about the process. And then being accountable by creating a plan, by creating goals, and by saying, really formalizing that commitment to doing something. And so I will pop those links in the chat and I will turn it over to Priscilla.
So PK, in the interest of time, what I'd like to do is offer some tips, because we've got maybe 10 minutes left and I want to make sure folks have time to answer questions.
Excellent. I think Donna's already said everything I needed to say.
Okay, excellent. I'm going to make sure that folks have access to a tool that I want to share that's around implicit bias. And it's basically implicit spelled out, and some steps you can take in your day-to-day work to ensure that you're addressing your implicit bias and acknowledging it and moving through it in the work that you're doing. But I want to offer a couple of before I turn it to Priscilla and Dawn to make sure that they can offer their practical tips. As we're talking, the thing that comes to mind to me, I'm doing a lot of work right now on trying to help young people in the field of public health know the difference between a mentor, a coach, a sponsor, and a connector. And in my research, I've learned, and we know this, right? Informal sponsorship has come for white men, and you all know, I think this is a safe space to say that public health as a field gets paler, maler, and staler the higher you go up in the ranks, right? A lot of the opportunities have come by way of informal sponsorship. I play golf with you on the golf course, or I go to the church, which is not a diverse church, and I get my name mentioned that I don't have access to. And I'm getting chills now because I'm reading how we still have a problem with sponsorship, particularly for people of color and even for women. And so all of us on this line, we have a responsibility to be better sponsors. If we want to see a reduction in the racial health equity gap, we need to see more diversity in the field in leadership roles. We need to see 75% of the field is made up of women, but only 25% of leadership roles are held by women. We need more women in leadership roles. Those of us who have access to rooms need to be sponsoring people of color and women behind us so that they have opportunities to grow their profession. That's how a lot of this can change when the lens through which policies and practices are being created changes. And then I also want to mention that having worked in public health for 20 years, there were many days when I felt like the field of public health was betraying me. It is very uncomfortable and very triggering to know that when I first joined the field and learned about infant mortality statistics, that those numbers have not changed. It is very triggering to work in a field where when you want to talk about minority issues, you tend to still get put into a track or one session that's on minority health or health equity. When the reality is minority health and health equity needs to be embedded in every single session at every single conference you have if we're going to address and reduce the racial health equity gap. From my lens, this sponsorship and this idea of not ghettoizing, of really being inclusive around health disparity related issues, minority health in everything, because it affects everything. Those are the points that I leave. This other stuff I can send you a link to. Dawn, practical tips, frameworks, practice pointers for doing this work through an anti-racist lens.
Yes, so this is a list that I developed based off of what I was seeing in declarations, but I think it applies whether you've issued a declaration or not. These are all things that you can do. Number one, and most important, is normalize conversations by race and health about having them. So we're never going to get to, some people are uncomfortable with systemic racism, right, and the language associated with that, but we're never going to get to a place where we can do something about it if we can't talk about it. So keep doing that, but also remember, you need to talk to people in a way that resonates with them and be conscious of where your audience is. Another common recommendation that I think is important is establishing a task force or working group that includes community partners. And also I see in the chat, and not just have the one person, minority person be the DEI director. Think about the composition of the group when it comes together and its purpose, which is to help create a culture within your organization. So you can't just create a work group and then expect that to change everything. The whole organization has to buy into the mission. You want to systematize the use of racial equity tools in your organization. That includes in performance management. So setting equity related targets in performance goals, in job descriptions, and things like that. So strengthening data collection and evaluation and requirements for reporting. If you don't have a policy around how you collect and use data, or it's not clear on how you use data on different population characteristics to inform your practice, then you need to get one. You need to develop one. And there are people out there like the Network for Public Health Law, right, that can help you to figure out how to do that. Put money toward the things that you say you're going to do. Put resources toward things you say you're going to do. And remember that you're not in it alone. So where are the foundations? Where are the nonprofits? Where are the businesses in your community that have said that they denounce racism and said they're going to do something about it? Because they can also help fund some of these activities. And then the last thing I would say on this slide is just develop a racial equity plan, action plan with clear goals and timelines. That again has community perspective built into it and baked into it, and that community members who are impacted are part of also implementation. And so the next slide is just an example of a common framework for local health departments, and it's the Government Alliance on Race and Equity, Racial Equity Framework, which is a lot of what I was just saying, but it's normalized, organized, operationalized, and you've heard those terms quite a bit today. And so really what I would say is the first and most important thing, aside from addressing your own issues as an individual, is to build your organizational capacity first. You cannot go out and create change in the communities you serve if your organization hasn't done the work. I'm going to stop there because I want to be mindful of time, and also I could just go on forever. So,
and we only have an hour. We could talk about this stuff for days. PK.
Don has said everything that needs to be said. I think, we're short on time. And so I just put the 4 boxes here: listen with empathy and curiosity, seek to understand. Don talked about collaborating and building bridges, and then taking collective action. So, we're close on time. That's all that I wanted to say with regard to that, Montrese. And so we can go forward.
Priscilla,
Yes.
this is Katie. And also Montrese, you all have another half hour if you want it. So if you want to take a few more minutes to expand on some of these concepts, we are all ears.
Well, we can definitely do that for sure. I want to see if we've got questions from folks in the audience, but PK, do you want to expand on any of these ideas?
I know we have a half hour, but I want to give time for Q&A. Okay. The first block that I put in terms of listening with empathy and curiosity, often we come to the table, again, we've talked about this with preconceived notions of what we think it should be or how it should be, and even with our own biases. But I would advocate that you come with a heart of empathy, and more importantly, with curiosity, asking those questions that need to be asked. Even, we often preface it with, this may sound like a stupid question. There are no stupid questions. And you need to ask those questions that you think need to be asked. Secondly, Stephen Covey years ago would have this saying, seek first to understand, then to be understood. I think that is so important in terms of how we do this work and where we do this work. If you're listening, oftentimes you're seeking to understand what actually needs to be done, what's actually being said. And so for me, that is the second most important building block in this. Third, it's really important to collaborate and build bridges. Coming from a community benefit background, which was my most recent assignment, it was very important to build those bridges in the communities in which you serve. You won't be able to build the trust if you don't build those bridges. And as Don most eloquently said, you have to do the work. And sometimes the work is not easy. It's hard and often dirty. But when you build those bridges, it often leads to fantastic results, but you got to get there. And then finally, taking that collective action, pushing forward. I used to have an on, and we've heard this phrase, either put up or shut up. That's really what it's all about. where are you putting your money? Because where you put your money tells me what you think is most important. That goes from employment to community benefit and where you're actually focusing those funds. And so when you take that collective action based upon the mission and the vision that you have in front of you, and you continue to put in front of you, it leads to something that is far beautiful than what you first imagined, but you have to get there. And so I won't belabor the point with regard to that, because I think Montrese, you and Don have really built the bridges with regard to getting to this point. So I will just stop there.
Thank you, PK. That's helpful. I think it's actually helpful for some of the questions that I see here. I'd like to go ahead and start on questions if that's okay with you all.
Can I say one follow-up to Priscilla real quick?
Absolutely.
Yeah, to her comments, which made me think, another important thing that I didn't emphasize enough, but I think you've heard her, just describe, is the importance of leadership buy-in. I mean, one of the challenges, particularly in health departments, is having a leadership team that backs up the work and not just having your designated diversity officer or equity officer being the one leading the charge. And the other important thing to consider is what is the burden on an executive of color in having an agenda, right? And so if they want to drive and say a racial equity agenda, how much is that going to be affected by the perception that they're only doing that because they're a person of color in that position? Yes. Right. And so that is where other leaders in the organization who are not people of color need to step up and say, no, this is a value we all hold, and take steps collectively to make it happen. So just be conscious of that. I think that's also being anti-racist, right? Is just asking a question and saying, this person can't be the only one leading the charge. So
I was told early in my career, Dawn, by a colleague of ours in public health law, you don't want to focus on minority health issues. And at first I was like, you don't want to, I get that you're a Black person, you care about those issues, but you don't want to focus on that. You need to, this was the advice that was given to me. And when I heard it, I didn't like it. I think I may have told you this before, PK. When I heard it, I didn't like it. I was offended by the language, but he ended up being absolutely right because the nature of our field. His thoughts were, if you can go demonstrate expertise in something that the white folks value, then you'll be able to establish yourself in the field and you might be able to talk about minority health issues and have a voice that they may listen to. And that's a shame. Because what happens is I work with a lot of African-American young and students of color, of all sorts of color, and young professionals in the field in my coaching practice who talk about these issues, but feel like they've got to whitewash them so that they can get some space in the room. And so I think this idea of normalizing this conversation is critically important, and getting to some consensus in the field of public health around the language that we're going to use and what our ultimate goals are. With the questions that we've received, I'll start with the first one that I see here is, are there evidence-based methods for conducting equity audits of policies and systems? Now, I know that a nonprofit called Beloved Communities does equity audits within organizations. They'll do an equity audit around your hiring, governance within an organization, so policies and practices within an organization. I don't know that something like that exists specifically for our field for public health. Dawn or Priscilla, have you guys seen any evidence-based methods for conducting equity audits of policies and systems?
I have not. I will be honest. I have not at this point. I think asking that question 5 years from now, you might get a different answer. And so for me, Don may have a different answer, but I currently have not.
So I saw that question come in, and I was curious about the kind of audit or the kind of tool that, is the question is about. And so there are a lot of great tools out there. We have one out at the network. There, King County, Washington, Seattle have great racial equity tools in place to examine laws and policies. Yeah, somebody just put it in the chat. So those are great. And the nice thing about King County is, I mean, they started over a decade ago trying to do this work of integrating racial equity throughout all of government. And so I think those are some great examples. I think we can probably share a list to send out after the webinar. So the network, we have a tool. There's an equity lens tool for health departments that was put out by Big Cities Health Coalition that is good also. And the one thing I would say is that a lot of these tools have a lot of commonalities. And the important thing is to do what makes sense for you and your organization. And the important thing is to use a tool. You know, it doesn't have to be a perfect process, but you have to start somewhere. And then these tools all have very similar guidance. And so that would be my response to that.
Thank you, Dawn. I seem to have lost the chat. Let me find that again. There it is. So there's some good sharing happening in the chat here. Let's see. Another question that we saw was related to policies. All right, so an organization has a frequent no-show policy that was just started. The person in the chat box thinks it's horrible. Just don't think that barriers are being taken into consideration. It's interesting that a frequent no-show policy would be instituted right in the middle of a pandemic. But the question is, what is your input on a frequent no-show policy? And I guess potentially the biased or racial impact of that.
Let me ask the question, is this in relationship to people with appointments? I don't understand.
People at work. If you don't show, I'm guessing.
Oh, see, I thought it was appointments. Yeah.
It might be appointments.
Is it medical appointments?
Yeah, it's just like you like miss like 3 appointments and then you're put on this like you have a flag on your account that you can no longer like make an appointment. And it's like there's so many barriers, like ride, like, you know, just all the barriers that it's like, are you calling these people to ask? Like we have these teams and it's like, are your teams calling the people to ask? Like, sorry, I'm trying not to ramble, but it's like, are you calling to ask what these barriers are and what you can do to fix them to help them get to their appointments? Because obviously they wouldn't be making these appointments if they don't need them. So
yes, and basically by not giving them any more appointments, you're saying, okay, you're on your own now because you weren't able to follow the rules. There's so many social determinants that can be barriers and impactful there. My mind immediately goes to research. I want to know, okay, so what's the population that's not showing up? What do they have in common? Because that's the social determinant that particular health system might need to be focusing on as a priority. But Dawn, what are your thoughts there?
So when I worked in state public health, this question came up for like our FQHCs often. And so number one, I know there's evidence about whether or not these policies work. So one is, I would say, gather yourself some evidence to have a conversation. I'm a huge data person and believe, support what you can with research. The other thing I would say is if you need to put your own tracking in place. So the important thing that we should do with any policy we implement is track its impact. So now that you're implementing this policy, just some of the things that Montrese was saying, who is it impacting? How is it impacting your client base? How is it affecting your bottom line? So you need to identify some measures that say whether or not the policy is working. So a lot of times organizations will put a policy in place and then do nothing to measure its effectiveness. So that's would be a second recommendation. Another thing is I agree, with the recommendation and is to survey why people are not making it to their appointments. I do know of a study that was available at the time, this was several years ago, but there was a clinic that showed that text message reminders helped increase the attendance rate. So it could be something very simple, is that people they don't have a calendar or a way to track it, and having those reminders helps them to adhere to their appointment schedule. So looking at ways that you can proactively also try to ensure that people make their appointments and don't miss them. And so whatever that service is for you, obviously you have to take into account the costs, right? The resources that go into that, but is sending an automated text message reminder, not a very cost-effective method? And probably is. So you should consider options like that.
Thank you so much. I appreciate it.
Thank you for the question. PK, do you have thoughts on that from your RIP medical debt lens? It just seems to me like there's a connection there.
I have it from having worked in a hospital system where, and I can probably guess where the large percentage of those no-shows are coming from, and some of the reasons why, in terms of transportation, in terms of I have to go to work, I don't have a babysitter. So there are numerous, and sorry for the phone, there are numerous reasons as to why. I think Don gives some good points in terms of trying to understand why you have those numbers. And then if it's transportation, how do we help this person get that transportation? And here's where I would also say, once you get that information and you have the reasons why, you need to, I would ask, if you are in a hospital system, to reach out to your community benefit team to look at ways in which you can help that particular demographic to bring down the number of no-shows in terms of what programs do they have to offer that will help you get those patients to their appointments. And so again, find out the reason why, and then look to those programs that could actually help with regard to getting the patient to their appointments. I can say, lastly, that with the no-show and then being put on the list, you may get some patients who will start to show up to their appointments, but there are others, and probably a majority of those just don't have the transportation. There's something that's happening that is keeping them from coming or adhering to their appointment times. So, that's what I would have to say, but I have seen that. I have seen the restrictions as well. And it's all about the bottom line.
Thank you so much, Priscilla.
Yes.
And I would just add,
Go
sorry,
ahead, Dawn.
I just want to add really quickly, Priscilla, you reminded me of the importance of engaging community health workers and care coordinators, especially for clients who are covered by Medicaid programs.
That's right.
Right, as a way to bridge that gap. And I didn't even think about it, but yeah, I mean, that would be an important way to help draw those connections and make sure not just that people are making appointments, but they're also following up on any other recommendations from a prior visit.
Right. Yes, those community health advocates are really important in terms of helping to bridge that gap.
So there's a question here. It's kind of a broad question, and I'm not sure how I would answer it. So I'm going to flip to you all first. Please address those of us who are boxed in those categories, Black, etc. How to advance through an organization that tends to categorize ethnic groups. I'll just say, I think most organizations, because they're made up of people with our own individual biases, and we come together and all of a sudden we've got these collective biases. I think that most organizations tend to categorize people into boxes, whether they do it purposely or not on purpose. Part of one of the messages that I hope we offer you that you can take away in this conversation is that we need to look at some of those unspoken messages, some of those implicit the ways implicit bias shows up in our hiring and our processes and who gets to do what job. But I'm gonna turn it to PK and Don. My perspective on that is you got to call it out. And some folks are in positions. I mean, I've been doing this for 20 years. I feel like I'm in a position to call it out. But 20 years ago when I first started my job, I might not have been. So let me think on that a little bit and see if Dawn or Priscilla have thoughts on how do you advance through an organization that tends to categorize ethnic groups. Who wants PK?
Okay, I'll go for
I'm sitting here thinking.
I do think this is a difficult question because I think for every person, it's going to be different based on your own, it's hard to say what your organization is like. I will say for my own personal experience, anybody who knows me knows that I say yes to opportunity. And so I think that means if a task force comes up or an opportunity to join some dynamic women on a panel comes up, think about doing those things and establishing your value through those different activities, right? And so that leadership above you can see the value that you bring to the organization and the ways that you engage. And then also kind of proactively seek out those opportunities. And so, you know, is there a way you can be involved in a board or a task force or an advisory group? And how engaged are you, frankly, in your community? So I think that having that network of people who see your value can go a long way toward those people in the community who are leaders with power can communicate to people in your organization who have the power. And I see that a lot on the ground here in St. Petersburg, you know, the influence that a lot of our local leaders and networks have over a lot, you know, as part of the policy conversations that occur here in the county. And so I would say being involved as a community member is just as an important part of, you know, being involved and engaged as an employee.
I agree wholeheartedly with that. And I would say seek out, you know, we've talked about seeking out people who don't look like you. I would definitely seek those people out, those who look like me and those who don't look like me. Don't be afraid to, I'll give you an example. When I was beginning my career, I had a cousin who is a banker who said, you need to figure out what's actually happening with your Chamber of Commerce, because that will tell you what jobs are coming in, where the community is going, who are the leaders within that community. And so what I did was I sent an email to the VP of HR at the company that I worked to say I was interested in getting involved in the Chamber of Commerce. I knew that this person was interested, who had a voice on the Chamber of Commerce. He put me in touch with the chairman of the Chamber of Commerce, and I got a meeting with him only because I reached out to the VP of HR and had my thought about what type of organizations or activities I wanted to participate in. And so one thing led to another in terms of, well, you need to meet this person. And so I would say, don't be afraid to take a risk. Don't be afraid to be vulnerable, to say, I really want to learn about this. You have the key to that information. Can you help me? The answer will either be yes or no. And if it's yes, that's great. If it's no, then you move on to the next person, because that one person doesn't hold the key to all of the information. Get involved. And finally, I would say, know your value up front. Before you go to ask, you need to know what your value is, know what it is that you want, and know how to express it. Because you only get 90 seconds to say what it is that you want to say. And then after that, you know, our attention span is small. So it's like your elevator speech. Have that elevator speech ready to go.
I agree everything with Dawn and PK. I think my thoughts are, the reality is I do fit into the Black woman box. I might not fit that stereotype, but if there's a box to check around an African-American woman, I am it. You can check that box, right? I think the problem is the lens through which other people see what Black women are capable of that bothers me. And I have found throughout my career that even in the most, in places where they're saying they're anti-racist, again, it's individual biases that show up, where white men can publish books and textbooks all day long and not have any trouble. But the minute that I'm trying to publish a textbook, everybody's paying attention to every single detail and every little piece that I'm doing, until finally I have to ask the question, why are you paying so much attention to me when you're not paying attention to the Black man? Obviously, I have to be doing something wrong because I'm a Black woman. They're doing it right. We're not going to pay attention. That's real. That happened. Those things happen and they impact your career. You might have to leave. That's what I did.
That's the last point I wanted to say. If you're not where you are being celebrated, or
and when they say to you, when you ask, well, why didn't you look at the white man so closely and what they were doing? Because they were doing exactly what I was doing. Why am I in trouble for or almost in trouble for what they were doing? And then the response is, oh, we probably should have been paying just as much attention.
Yeah, I'm double clicking on that.
It was 19 years. It was actually 19 and a half years. Yes, ma'am. And the interesting thing about that is the other side was so much better. I'm in so much of a better space. I just never
Yeah,
could
but you have to
imagined.
follow out. You have to say to yourself, I'm worth, as you say all the time, Montrese, I am worth taking that risk. You bet on yourself.
You bet on yourself. Now I know Pamela, I see her over here. She's after 13 years leave. I know it's easier said than done, but you got to stand in choice. And if you do think you're as valuable as you think you are, then your value will be valuable even beyond that. I was recruited. Once I left my job, people came to find me to continue to do this work. And
while you all were speaking, I promise you, I'm glad I'm muted because I did the church thing and hollered and celebrated what you all have shared with me. I appreciate it. And don't think that it was not well received. I appreciate every statement you all have made.
thank you for that.
Thank you.
Thank you.
I just want to
I'm glad
add,
it was of value. Go, Dara.
I am too. And I want to add in, for me, this is tying it into our current situation. You know, we have read reports about life expectancy declines for Black and Hispanic and Latino people due to COVID, and it's horrific. And for any of us who've been touched, who've lost family members to COVID or to anything else really, know that life is short. And so I think, I mentioned that especially in this moment, because it's like, we don't know what the future with COVID looks like. We don't know what this next year is going to look like. People are still, unfortunately, not making any good plans. And life is short. And do you, I think you have to ask yourself the question, if you want to spend that time in a place that doesn't value you, where you can't be your best self. I think that's worth a question asking, no matter where you work and what you do.
Yep. And I think COVID has shined the light on that for a lot of people. There's a question here while we're talking about, we're talking about how to recruit more people of color strategically. What ideas could you share on that? I will say one of the things that we've really had to do was look beyond the traditional folks whose resumes would cross our desk in public health. It's very easy to look at a resume. I've been doing this again 20 years. I can look at a resume and be like, oh, this is a perfect public health person. When someone else who would be a perfect public health person just hasn't had the access. I would not be in the role that I'm in right now if I were to show up with the resume that I had 20 years ago today. I had no idea what public health was. The fact that I was able to get a job at CDC is miraculous. I wouldn't hire me. And so I think it's important that we dig into the trenches and recognize that there are a whole bunch of people who have skill sets that are valuable to public health, who can be grown into public lovers of public health. You might have to dig into the trenches. People whose GPAs might not be as high as you want them to be. People who did not necessarily go to the hot top public health schools. People who maybe didn't get an opportunity to do an internship at CDC or at some national organization, but demonstrate hunger around the field is critically important. I also think it's important that we go beyond the traditional HBCUs. There's 4 HBCUs that everybody tells me they're recruiting at. And there are so many more than that across the country. Also, if you want to recruit people of color and you're in the state of Minnesota, I'm just using that as an example, you might need to offer them an opportunity to work remotely. I've had so many students, Black students, who just cannot fathom living in the state of Minnesota, working in Minneapolis, because the heaviness of the history and the way Black folks are being treated in some of those places, at least anecdotally, what we're hearing, right, impacts whether or not they'd be willing to do the work. So if you're in a place like that, you might want to at least allow them to work remotely and come in once a quarter. There are ways that you can get to more diverse people by offering incentives that are universal across the board. I'm not talking about anything that's inequitable.
Montrese, I don't know if you even saw this, but there's a question in the chat box that just came in about learning how to recruit people of color more strategically. So I'm just lean into that even more. What other ideas do y'all have?
Yeah. How do we recruit people of color strategically?
So one thing, I guess, I think you're saying also, what is your network? Going back to the Harvard example, if your network does not have diversity in it, whose network does that you are connected to? I mean, you have to think about outside of your own little bubble in terms of who you're reaching and how you're reaching, and maybe engage other people to help you get the word out. I mean, one thing I was thinking, depending on the level of position, is go to the people. do job fairs and rapid hire events that you in communities that are more diverse, and take the job to the people and get a sense of, have your HR staff on site to interact with them and get a sense of who they are, or your hiring manager, whoever it is. I mean, that's one way to do it for certain types of positions. We had a lot of direct care for our state-run health facilities. Partly we started doing rapid hire events because we just had high turnover and had a hard time keeping employees, because it's, low wage, job that doesn't have a lot of thanks often. But also it's a way to recruit in neighborhoods and communities where you may be able to find workers who are wholly qualified and who maybe just were not aware of or didn't know how to access your application process.
Yeah, I think what Don and Montrese have said, they've offered a lot, so I won't belabor the point. But I would just say, give, as Montrese has said, give those people who don't have the high GPA, who didn't go to one of the 4 HBC schools, didn't go to the top 5 public health schools. Give them a chance if they're hungry to learn, because chances are you might be better off with that person as opposed to someone who fits everything, but is not the type of person, once they're in that position. What am I trying to say here? I'll just leave it at, give those that you normally wouldn't give a chance an opportunity. There's so many of us out there.
Yes, but then there's the other piece of, if you get them, can you keep them?
Well, that goes to your policies and beyond your policies.
And that sense of belonging, that culture of belonging. If I don't feel like I belong, I mean, and I'm going to tell you, public health has a belonging issue with people of color in many instances, because if I'm showing up every day and the infant mortality rates are not changing, I don't feel like I belong. We're not really worried about my issues. When you do this performative work of declaring racism a public health crisis, but just say the words and do nothing with it, that negatively impacts my sense of belonging. If I show up in the field, and I've had this happen where, again, I'm saying it all. I'm just saying it all on this call. But I was in charge of our internship program, and I went to my boss and I'd be like, I'm going to hire, half of our interns are going to be people of color, not on purpose, but that's just who's applied, and it's going to look like that. And he's like, we've been in roles, we as in white men have been in roles of leadership to hire for many, many years. And we've hired people that look like us for many, many years. Go forth, Montrese, do what you want to do in your role as a leader in this role. Then I hire these people as interns, and they go around to try to find a job, and they come to me and they say, we were under this false impression that public health was a diverse field. And in many ways, public health is a diverse field. But once you've got a law degree and a PhD, which is what these folks have, they're looking for leadership. They're looking for diversity in research. They're looking for diversity in epidemiology work. And we've got some problems there. So you can get them, but can you keep them? Who's going to mentor these people? Who's going to provide a safe space for them where they don't have to talk about the context of why they're feeling uncomfortable because someone said, I'm going to beat you to you commit or whatever. Like, those words can be offensive to people of color, but if you having to explain that context to somebody is often difficult. Or and why an African-American public health practitioner won't ride the elevator with 3 white public health practitioner women. My employee didn't have to explain that to me. I understood that. And so this is why it's not just can you get them, it's can you keep them? What sort of environment are you creating where someone can express, I feel uncomfortable getting on the elevator with 3 white women, because they could say anything they want to say and I'm going to get in trouble. And then you say, which is what I said, you might be thinking too hard about this. No, this is what I've experienced before. Or I show up and I express I don't like something, and because I'm a Black man, it sounds a little more assertive, and so I get reported to HR. If you get them, can you keep them? What are we doing to create environments where we can ensure true inclusivity and a sense of belonging? Obviously, this matters to me. Don, Priscilla?
I concur.
I'm muted.
Oh, that was me.
Am I unmuted? Okay.
Yes.
I want to say one very important actionable thing, that if you are in a position to approve people engaging in professional development and leadership opportunities, approve it. I know so many people who work in organizations who get told they can't do something because it's not related to their job description, especially in governmental public health. That is unacceptable. Our job as leaders is to build people up and to help them go on to the next step in their career. And if you're denying people opportunities, then you're not doing your job right. And then also I would say you need to seek out opportunities yourself, right, for leadership and professional development. And often that can be hard, but I think that's an important part of retention, is having those opportunities and advocating for yourself to be able to participate in them.
I agree with that. If nothing, you don't take anything else from that. You are your own advocate. You know, people will come along the ride with you if they see you pushing the car down the road. So you have
People
to
will
speak
believe in
up.
you if you believe in you. That's
right.
Yes.
That's right.
Yes.
So this has turned into a full-on coaching session, but I certainly hope it's been value added to all of you all. I know that I've enjoyed it. I've learned a lot, and we're gonna make sure. Let me make sure before I give it back to Katie. This is our contact information. If anybody would like to reach out to us, we're basically taking this on a road show. So.
Oh my goodness. I can't even say enough right now. I'm so grateful to the three of you. Thank you so much, Priscilla Keith, Don Hunter, Montrese Ransom, for an absolutely fabulous, best I could have imagined ending to our series here, to our Sizzling Summer series. Really bringing all of the ideas together from across the summer. The kudos are all over the chat box. So it's not just even me saying that, it's everyone saying that. I'm so grateful. Y'all, if you want to hear more from our speakers, you can follow them on Twitter. I've put a couple of their handles into the chat box, and Montrese, add your handle if you can find it. I couldn't find it. I did try, so add it in there. While I close up here. Thank you everyone who participated in our series today and or any of the calls that we had. Thank you for attending this Sizzling Summer series, session 5 in particular, approaching practice with an anti-racist lens, where we had the opportunity to hear from 3 amazing speakers on how to bring all of this information from the summer together. An evaluation will be sent for this call in the next 24 hours. We appreciate your support and completion of that evaluation. It helps us to think about content for future series, future Sizzling Summer series, quality improvement on our trainings overall as the Midwestern Public Health Training Center, and of course, reporting purposes to our funders. So thank you so much for filling out those evaluations. And from all of us at the Midwestern Public Health Training Center, I'm going to call out Lori Walkner, the director of the training center, the folks in Iowa, Kansas, Missouri, and Nebraska. Thank you for joining us for this series. We look forward to collaborating and partnering with you to move our field forward toward a strong, equitable, anti-racist workforce and system. And we're thankful that you are willing to take your time to join us in the discovery around this. So happy summer, everyone. Take care. Thanks again to our speakers, and we'll talk to you soon.
Thank you.
Thank you.